Hello, I'll be presenting my research looking at outcomes and trauma patients by mode of transportation. Over the last several decades, robust trauma systems have been established to rapidly transport patients to an appropriate trauma center by emergency medical services, also known as EMS. The concept of the golden hour, which is the first 60 minutes following injury, was first described in the 1970s. While the actual time frame of 60 minutes is somewhat arbitrary, this concept really emphasizes rapid transport to definitive care. EMS has even taught the Platinum 10 minutes, in which their goal is to limit scene time to only 10 minutes. The importance of rapid transport is widely recognized. It is intuitive that trauma patients should be transported quickly to a trauma center. However, pre-hospital trauma care varies significantly between and even within trauma systems. This pre-hospital care that trauma patients may receive ranges from the scoop and run method, which focuses on immediate transport to a trauma center without any interventions by EMS, to the so-called stay and play method, in which EMS attempts to stabilize the patient on the field prior to transport to a trauma center. There continues to be some debate between these two methods, but more and more evidence is coming out that questions the benefit of advanced life support type interventions provided by EMS. This includes IV fluid resuscitation and airway management beyond bag mask ventilation. The thought is that increased interventions such as these delay time to definitive care and may also cause unwanted physiologic derangements. There's a lack of studies evaluating the effect of mode of transportation on outcomes. The studies that do exist primarily look at penetrating trauma only, or compare EMS to police transport or advanced life support EMS to basic life support EMS. There are many patients that arrive by private vehicle and therefore do not have the opportunity to receive pre-hospital interventions. This is essentially the scoop and run method in its purest form. This population has been underrepresented in previous studies. This leads us to our research question of, does transport via EMS offer a survival benefit over transport via private vehicle for patients that require the highest level of trauma resuscitation? We performed a retrospective study using data obtained from the St. John Trauma Registry. We included all patients who received the highest level of activation over a 5-year period. Patients that were transported by helicopter or police were excluded. We also excluded all patients that were dead on arrival. We collected and compared demographic data, injury characteristics, injury severity score, revised trauma score, and mortality between patients transported by EMS and private vehicle. Chi-squared analysis and students' t-tests were used for univariate analysis, and logistic regression analysis was used for multivariate analysis. In total, there were 1,693 highest level activations included in the study. 31.7% arrived by private vehicle and 68.3% arrived by EMS. Patients arriving by private vehicle were younger, more likely to be male, and more likely to be Black. They were more likely to have a gunshot wound to the torso, a higher GCS score, lower ISS, and higher RTS. On presentation, patients in the private vehicle group had lower mean systolic blood pressure and higher mean respiratory rate. Patients arriving by private vehicle had a shorter mean length of stay, were more likely to be discharged home, less likely to be discharged to a rehabilitation facility or long-term care facility, and ultimately they had lower mortality compared to those transported by EMS. As shown in the previous slide, patients who arrived by private vehicle had a lower risk of mortality compared to patients arriving by EMS. However, the police transport and EMS groups were significantly different in many aspects. So after controlling for demographics, injury severity, and injury type, there was actually no significant difference in mortality. Next, we performed a subgroup analysis to determine if there was a difference in mortality based on ISS. As expected, patients with lower ISS had an overall lower mortality, and patients with higher ISS had an overall higher mortality. Interestingly, we found that for lower ISS, patients transported by private vehicle had lower mortality compared to EMS transport. This was a statistically significant difference. There was no difference in mortality based on mode of transportation for patients with higher ISS. In conclusion, pre-hospital time to a trauma center plays an important role in trauma outcomes. Private vehicle transport is not associated with significant mortality differences when compared to similar patients transported by EMS. In our subgroup analysis, patients with less severe injuries are more likely to survive if transported by private vehicle. There are some limitations to our study. It is retrospective, it is single center, and it is not generalizable to non-urban trauma centers in which patients are not in such close proximity to the trauma center. Overall, these results continue to support the scoop and run method and indicate that prehospital interventions may not be necessary.